Well, thank you so much for the introduction and for having me here tonight. If at any point you can't hear me, let me know, okay? And this is pretty informal. I'm going to go over kind of the major types of skin cancers. And if you have questions or don't understand, please let me know and we'll address it. And I'll have time at the end too, so we can go over stuff then, okay? Linda pretty much introduced me, did everything. I'm from Colorado originally. I love the outdoors, and Colorado just got too busy for my husband and I, so we love it up here. So tonight we're going to go over what is skin cancer, what causes it, how do we recognize it so you can help me help you, how do we treat it, and how do I prevent skin cancer. And this is my niece, Olive, and I think I bought her this cute little outfit. So she will not get skin cancer because she lives in the Cayman Islands and she's super fair. So 1 in 5 Americans born this year will develop skin cancer in their lifetime. So we know that the incidence of skin cancer is very high and it affects everyone in some way. So why is this important for all of us? The skin is the largest organ in the human body. It forms waterproof protective wrap over your entire body. It serves as a barrier to infection, and it helps to control your body temperature. It does some other cool things like vitamin D synthesis, which is not so important up here because we really don't get the right UV radiation. The average adult human skin has a surface area between 16.1 and 21.5 square feet. And in just 1 square inch of the skin, there's approximately 60,000 melanocytes. And these are the cells that give pigment or color to your skin. There's over 1,000 nerve endings, 650 sweat glands, and 20 blood vessels. So the skin is super complex. So here's just a nice pictograph of what your skin looks like when we look at it microscopically. There's basically 3 layers. So the top layer is the epidermis. That's the outer layer. That's the area that provides the greatest barrier. It's also where we get the most sun damage and see where our skin cancers arise from. The second layer is the dermis. That's where all the blood vessels, the hair follicles, sebaceous glands, or your sweat glands, that's where they arise. And then the next layer is the fat layer. And that's just kind of lots of fat, lots of blood vessels, not so important for us today. Just a closer look at the top layer. You can see you've got lots of different cells here, and this is where we're going to see most of our skin cancers are arising from. And then again, the second layer, more in depth of the hair follicles, the blood vessels, nerve endings. Not so important for skin cancer today, but very interesting for me. And then the last layer, which hypodermis or subcutaneous tissue, and that's where all your fat is. So nearly half of all new cancers are skin cancers, and more than 1.5 million new cases in the US this year. And I'm going to have you believe by the end of this that the sun is not your friend. So what is skin cancer? Well, like any cancer, it's out of control growth of abnormal cells in that top layer of skin that we talked about, the epidermis. It's usually caused by unrepaired DNA damage that triggers mutations that leads to this out of control growth. And then the skin cells multiply rapidly and form malignant tumors. So the 2 main causes of this out of control growth is the sun's harmful rays, the UV rays, and tanning beds. We also are finding out that genetics plays a big role in some types of skin cancers. And so if you have the right combination of sun exposure plus the genetic makeup, you're at a much higher risk for skin cancer. The good news is that we can see the skin. We can see the tumors forming. And so if it's caught early, we can oftentimes treat skin cancer with relatively no scarring and really high odds of eliminating it entirely. And oftentimes we can even detect abnormal growth at the precancerous stage before it's even become a skin cancer. So that's what we want. That's our main goal, is to help you guys detect when you've got new precancerous lesions that we can treat early. So ultraviolet light, we'll just talk about it really quick. There's two things that we're most concerned about, the UVA and the UVB. You might hear these terms thrown out a lot. So the UVA, these are the tanning rays. This is when you go to Hawaii and you get your tan in January. So it penetrates pretty deeply into the second layer of skin. It causes suntans, sunburns, and sun damage. It breaks up a lot of that collagen tissue, and if you have chronic sun damage, you get lots of wrinkles and that leathery brown skin, which I saw all over Florida when I was training there. The UVB, this is kind of referred to as the burn index. It causes suntan, sunburn, and sun damage as well, but it also causes that long-term sun tanning, I think, which I saw a lot in Florida, where just people are leathery skin. And both of these can lead to skin cancers. So effects of sun exposure. You can have permanent destruction of the skin supporting structures in the second layer of skin, premature wrinkling, the precancerous lesions, drug reactions. So if you're on medications, oftentimes the sun can have an effect on your skin. You can have a horrible rash. Eye damage, it affects the eyes the same way as the skin. It can lead to early vision loss, dilated blood vessels on the skin, sunburn, and of course skin cancer, which is what we're most concerned about today. So again, here's my top layer of skin. This is the outer barrier, the place that's most affected by the UV rays. And just of note, if you see the green cells on the bottom, those are melanocytes, and we'll talk about those when we talk about melanoma. So here you see, a picture of this beautiful baby skin, no sun exposure, next to, a weathered hand that's obviously been exposed to sun. And so we know that sun causes a lot of damage over our lifetimes. Lots of wrinkles and hardening of the skin. So who's at risk for skin cancer? Well, I'm going to tell you anyone can be at risk because I've seen skin cancer in everyone. But people who look like me are probably at the highest risk. You have very fair skin. I'm considered skin type 1, so I'm pale. I pretty much always burn when I get into the sun and hardly ever tan, and I've got blue eyes. So I've got every risk factor. Skin types 2 and 3 are also at pretty high risk, and so these are people who still burn and they may or may not tan. However, like I said, anyone can get skin cancer. Bob Marley died at a young age of a melanoma that just wasn't detected in time. So anyone can be at risk. So this is actually a picture of myself. It was in one of my mentors' slide set for his skin cancer talk. My father was a photographer, and it just cracked me up. I was sitting in his lecture when I was a medical student, and I saw my face flash across the screen. And it's funny too, because at that time I wasn't in dermatology residency yet. I was still striving to be there, and there I am. So I am at very high risk, and if you have any redheaded people in your family, they are at high risk too. We actually, new studies have just recently shown that there is a genetic defect that we have that leads us to a much higher risk of melanoma. So we need to be very careful in the sun. So other people who are at risk besides myself, medical and industrial X-ray exposure can lead to an increased risk. If you have scarring from diseases or burns, that scars have an increased risk of skin cancer. Occupational exposure to compounds such as coal tar and arsenic. And arsenic in well water can cause squamous cell carcinomas and precancers. Family history of skin cancer is important because it tells a little bit about your genetic makeup. Immunosuppression is very important. If you organ transplant patient or on long-term immunosuppressive therapies, you have a very high risk of squamous cell carcinoma and then an increased risk of melanoma and basal cell carcinoma. So the types of skin cancer, there's actually a lot, but the three most common are basal cell, squamous cell, and then melanoma. And so that's what I'm going to focus our talk on today, because that makes up 99% of skin cancers, and that's what's most relevant and most important for you guys. If you have questions about the other stuff, that's what I love, so I'll be more than happy to talk to you about it. So basal cell carcinoma, this is the most common form of skin cancer. There's more than 4 million cases per year that are diagnosed in the US. Basal cells are abnormal, uncontrolled growths that arise from the skin's basal cells in the epidermis. So it's the very last layer of that top layer of skin. Most often they develop on areas typically exposed to the sun, so face, ears, neck, scalp, shoulders, and back. And most basal cells are caused by a combination of intermittent intense exposure and cumulative long-term exposure to UV radiation from the sun over your lifetime. And so while basal cells rarely metastasize, they can be locally destructive, and they will just continue to grow and bleed and cause problems. So what does it typically look like? Usually we describe it as this pearly papule with some blood vessels that are running through it. However, the bump can also be tan, black, brown. It can be confused with an ordinary mole. So just so you know, dermatology is not always so easy. I don't always know when I look at something. Oftentimes, a patient will say that it was an acne bump that won't go away, or it continues to bleed or ooze. So anything that continues to do that for 3 or more weeks really causes alarm for me, and I think that I need to biopsy this and find out what's going on. Sometimes it can just be a little crusted patch that doesn't heal. Or it can sometimes be white and waxy, almost like a scar. So here I have a whole bunch of pictures of different types of basal cells at different stages. So the first, you can see that some of them look just pearly and kind of raised. Some are ulcerated with some crusting, and some have some pigment, so they almost look darker in them. And then here you can see a little bit of scar on the, can you see the arrow on there? Yeah. So in here you can see it almost looks like a scar, but then there's these funny little bumps in the center. And then these two basal cells are pigmented and almost just look like a mole. So here an important thing is to notice anything that's new or changing. Basal cells change pretty slowly for the most part, unless you're immunosuppressed, and then the change could be rapid. So the next type of skin cancer I'm going to talk about is squamous cell carcinoma. It's the second most common form of skin cancer, and it's an uncontrolled growth of abnormal cells arising from the squamous cells in the epidermis. There's more than 1 million cases that are diagnosed in the US each year, and this is usually caused by cumulative long-term exposure to UV radiation from the sun, and tanning machines cause most SCCs. As well, they're common on sun-exposed areas such as the ears, face, scalp, neck, and hands. This is where the skin often reveals signs of sun damage, including wrinkles, pigment changes, age spots, and broken vessels. SCCs can sometimes grow rapidly, and they can metastasize if they're not detected early. And if patients immunosuppressed, they tend to be a lot more aggressive. That just depends on the patient's status. So if you're young and healthy, that typically would take a while. But if you're older, immunocompromised, that could happen in 1 to 3 weeks. Yeah, so it really depends on the patient's status and how healthy you are. So what does it look like? It can look like a lot of different things. Sometimes it looks like a basal cell. Sometimes it looks like a wart-like growth that crusts and occasionally bleeds. Basal cells tend not to be symptomatic, so they're usually not painful. However, squamous cells often do elicit some sort of uncomfort feeling, so pain, a little tinge. So patients usually feel this. It can be a persistent scaly red patch with irregular borders that sometimes crusts and bleeds. And elevated growth with a central depression that occasionally bleeds, and it may rapidly increase in size. So here's some other examples of squamous cell carcinomas. This one's on the back of the hand. Probably this one's very verrucous or wart-like. This one's more crusty, and then this is on the lower lip. The lower lip is a common place to get squamous cells just because you get so much sun exposure and it's hard to cover it, and it's hard to protect it with sunscreen. Actinic keratoses are actually the precursor or precancer to squamous cell carcinomas. So this is something that we often look for on a skin exam, is because it helps, if we detect it at the actinic keratosis level, we can prevent them from becoming squamous cell carcinomas. And it also gives us a good insight into the sun exposure history of the patient. If they are covered in actinic keratosis like this patient, all these little red crusty spots are just precancers all over. This patient has had lots of sun exposure and is at high risk for skin cancers. And the actinic keratosis, if they're left untreated, up to 10% or more can turn into squamous cell carcinoma. So it is recommended that we treat them because we can do it in a non-surgical fashion. So treatment of basal cell carcinomas and squamous cell carcinomas, if they are invasive when we biopsy it, then surgical excision or Mohs surgery are usually indicated, especially if it's on the head and neck, because that tends to be a more high-risk area for nerve invasion and for spread of the cancer and local destruction. However, if they're superficial, we have lots of different treatment options. So there's topical chemotherapy creams available today. Radiation is actually a pretty good treatment for superficial skin cancers. And then there's this thing called electrodesiccation and curettage, and that's a scrape and burn method. It's old, but it works really well. And then there's some newer targeted therapies specifically for basal cells, which are for special patients who have really bad genetics and who are getting basal cells at the age of 10. There are now medications that are available to help prevent the progression of the basal cells. So that's not for everyone because it has some pretty bad side effects. So the last skin cancer that I'm going to talk about tonight is melanoma. So melanoma develops from melanocytes, and those are the cells that give pigment to our skin. This is the most dangerous and most aggressive of the three most common forms of skin cancer. Melanoma is often triggered by the kind of intense intermittent sun exposure that leads to sunburns. Tanning bed use has also been shown to increase the risk for melanoma. This year, they estimate that there's going to be more than 87,000 new cases of melanoma, and almost 10,000 melanoma deaths occur each year in the U.S. So melanomas often resemble moles, and they sometimes may arise from a mole. However, they can also arise from nothing. And the big take-home point for us tonight is that melanoma in situ is 100% curable by surgery. However, if it is allowed to progress, it can spread to vital organs and become life-threatening within months. So the AAD, which is the American Academy of Dermatology, came out with some guidelines to help us educate patients and yourself about melanoma and how you can detect it early, because honestly, patients, or the patient's wife, I should say, usually is the one who detects the melanoma. So A is for asymmetry. So if we look at the picture of the melanoma there, if you were to draw a vertical line and a horizontal line, in a normal mole you would have equal halves or equal quarters. In melanoma you start to see a lot of asymmetry on those sides. B is for border irregularity, so uneven scalloped borders, notched edges. C, color variability, so different shades of brown, tan, black, with progression to colors such as red, white, and blue. D is for diameter, so a diameter greater than 6 millimeters. And then E is for evolution, so anything that's changing, either size, shape, color in a short period of time. And these are just guidelines. So if you have a mole that is 1 millimeter, it's never changed, it's brown, but you say one border is asymmetrical, I'm probably not going to be too alarmed by it. But if you have 3 or 4 of these things in one mole, then I would definitely biopsy it. So different examples of melanoma, and these ones are all pretty advanced melanomas here. You can see the one on your left, I guess, has lots of different colors, scalloped borders. It's very large. This is actually a little superficial in-transit metastasis, so there's a little bump of new melanoma rising next to it, that little pink area. And then this is a very large nodular melanoma. And then this one on this older gentleman's face is probably a lentigo malignant melanoma, which is probably a sun freckle that has progressed into melanoma. So how do you treat melanoma? Well, like I said, if you catch it early and it's in situ, we can cut it out, and you probably will never see melanoma from that one ever again. It's 100% curable. However, treatment after that depends on the stage of the melanoma, which takes quite a bit of workup. So it depends on the depth of the melanoma, which we look at after we cut it out. We look at it pathologically, and the pathologist helps us to decide how deep it is. It also looks at how rapidly the cells are dividing, how ugly they look. We look at lymph nodes sometimes depending on how deep the melanoma is. Sometimes it's appropriate to do scans to see if it's progressed. And so depending on which stage will really predict how it is treated. There are a lot of great new medicines out on the market today for melanoma. Immunotherapies that help your immune system recognize the melanoma and fight it off, and really great success stories. Before that, there hadn't been any progress in melanoma treatment in like 30 years. So it's an exciting time, I guess, for melanoma cancer treatment, if you can say that. So how do we prevent skin cancer? This is the fun part of the talk. There's a lot of things that we'll go over. Most of them you probably know, so this is kind of fun, and I'm just going to kind of reiterate what to think about. So limit your time in the midday sun. And I was thinking about this, and I don't know quite how to adapt it to the Fairbanks summertime, because our midday sun is all day long. And it's pretty intense all day long. So I think I've gotten sunburn at 7 o'clock at night. So in the lower 48, I would suggest that you stay out of the sun's rays between 10 a.m. and 4 p.m. and limit your exposure during these hours. Up here, I would say you're probably if you're gonna be outside, you're gonna have to adapt a lot of the other suggestions that I have for you, such as seeking shade. So staying under cover is one way to protect yourself from the sun. Just remember that the shade structures don't offer complete protection. This is my nephew on the beach in the Caymans, and while he's covered up, he's still getting a little bit of scattering of UV light from the sand, and if he was closer to the shore, you could get that scatter of light off of the ocean. So he's got his sun protective hat on and his sun protective clothing and sunscreen, because I make sure of it. So cover up like my niece, wear your sun protective clothing. Long sleeves pants is a good way to protect your skin. There's so many outfits and different products available now that lightweight you can wear, that are breathable, that protect your skin. So anyone can do it, and they're affordable too. Use sunscreen, absolutely. So I say put sunscreen on every day, even in the wintertime up here, because you just never know how often you're going to be outside. And I say at least a 30 or higher. Apply generously and reapply often, especially if you're going to be outside. So how much is enough? They recommend at least a teaspoonful for your face, and then about a shot glass full for your body. So you want to be pretty greasy. Wear a hat, and this is my baby. This is Peyton. So I'm so ashamed to say, we went to San Francisco and we got sunburnt. All of us got really sunburnt. And so first thing I did when we got back is bought her a hat, and she never goes anywhere without it now. I felt so bad. I felt like the worst dermatologist ever. But yeah, a hat with a wide brim. It offers good sun protection for your eyes, ears, and the back of your neck as well. See, my husband isn't so smart because he's already got those little precancers on his ears, and he still refuses to get a broad brim hat. He won't wear one. So I keep working on him. Wear your sunglasses. It protects from the sun damage. This is my baby again, Peyton, with her sunglasses. Avoid tanning parlors. They do cause sun damage. They do cause skin cancer. There's been numerous reports recently. And some people say that they need to get their base layer tan. The base layer tan does not provide much sun protection, maybe a sun protective factor of 3 or 4 at most. So it's not worth the risk of getting a skin cancer. And we're seeing the rise in melanomas and non-melanoma skin cancers in young women, 30s, 40s. So they are way too young to be getting skin cancer. So don't let your daughters go get suntans. Watch the UV index. I just Googled this today, and it showed us the UV index for the next 3 days in Fairbanks, and we've got, it says about almost 5 it was at. So it says it's high, but not extremely high. And that's all I've got for you. This is Peyton. She says it's over. She's rolling over. Yeah.
There's always this pressure in Fairbanks about vitamin D and sunshine.
Uh-huh.
And that may be one of the factors, certainly not the only factor for the tanning beds.
Uh-huh.
But could you say something about vitamin D and
in tanning
you did
beds?
mention it,
yeah.
but you didn't really give us much encouragement.
Yeah. So the UV radiation from tanning beds is UVA, which actually doesn't help with the synthesis of vitamin D in our skin. And then you need UVB rays, which we don't get very well up here in the wintertime anyway, just because we're such a high latitude. So I just suggest taking supplements because I don't think tanning beds is worth the risk of skin cancer, and laying out unprotected up here doesn't provide us the synthesis of the vitamin D in our skin.
But in the summer, UVB is adequate?
I don't think I know enough to say. From what I've read, probably not, but I don't really think there's been enough studies of the radiation up here in Fairbanks to say 100%. And if it is strong enough, I would say, because when I was in Florida in training, what I was taught was 5 to 10 minutes unprotected in the sun is all you need to get that vitamin D. But any place above North Carolina really did not provide the right radiation to make that reaction in your skin. So I doubt that we have adequate UV rays up here in Fairbanks. But I don't know 100%, so yeah.
If you lived out in the bush and all of a sudden you discovered that you had a basal like you had in the bottom right hand, which was about 3/8 oval, but it had crusted over, it was now turning dark, if not black. Could you literally gouge it out with something and it totally bleeds and it scabs over? Is there a chance that you could solve the problem? Or does it go deeper than that?
No, with a basal cells like to be in the second layer of skin almost exclusively. So you would have a very high rate of cutting it out yourself. It would be very painful. And then the nice thing, if you know 100% that it's a basal cell, that's the other thing, is it could be one of the other skin cancers that's not treatable by just cutting it out. So yes and no. Yeah.
Could you go over the layers again? When you say the first layer, so you're talking about the very top layer of the epidermis. Everything that you're talking about is epidermis, is that right?
So the epidermis is this very top layer here. And it's layers upon layers of skin cells, but it's considered the top layer of skin. So it's the the outer barrier. And that's where most of our skin cancers arise from.
And so the squamous cells are which ones?
They are the ones kind of compact in between. They're closer to the top.
Uh-huh.
And basal cell is the very bottom layer, and melanoma, melanocytes are also in that very bottom layer. I think there's another. Yeah, this is a good slide. So the keratinocytes, that's where the squamous cells arise from. They're kind of all of these. And then you got your melanocytes and your basal layer.
And so, but basal cancers kind of stick there.
Yeah, they'll go into the second layer, too, into the dermis. I don't know who to pick. Okay.
Questions.
Uh-huh.
One, you do Mohs surgery.
Yes.
You're the only one in Fairbanks. is that
Yes.
right? Okay, good to know. Two, how many cases of basal cell carcinoma did you say are in the U.S.? 1 million for squamous, but how many for basal cell?
I think it was 4 million for basal cells and 1 million for squames.
Repeat the question.
Oh, she asked how many basal cells are diagnosed each year in the U.S.
And the third question is there any interplay between rosacea and basal cell carcinoma?
She asked if there's any interplay between rosacea and basal cell carcinoma. No, except for that a lot of people, or a high proportion of people with rosacea also are fair-skinned. So they're oftentimes at higher risk for skin cancers. How about you?
What dose back to vitamin D? What dosage of vitamin D do you
Grayson, what dose of vitamin D? Do you say 5,000?
2,000.
Oh.
1,500.
Okay. Hi, Dr. Swenson. We have 2 other doctors here. They can. For my, if you're a melanoma patient, I often suggest a high dose, so usually about 5,000. But yeah, just a regular dose for someone who doesn't have any risk factors. 2,000 a day?
Yeah.
Okay. Yeah, either one.
A lot of people are getting very tattooed, sometimes almost over their whole body. Do the different colors of tattoo ink or the fact that you're tattooed or not tattooed make any difference?
It makes my job much more challenging because you can't see anything evolve. And evolving melanomas is probably, that helps me out so much. If I can see a change rapidly, or if the patient can, we can often detect it so much earlier. So yeah, it's a problem for me. Yeah, makes my job scary.
Okay, I have, the surgeon I've seen a couple of times for me says they're now, nothing to worry about, they're called because of the tiki eye all over my back. But I go, can't see him and I hardly ever feel if they hurt me. But, so the question is, some people have said, oh, you need to go to a dermatologist about your, but if you find that they're not a problem, how often should you go back and have your back checked because you can't see your back?
Yeah, so she's asking how often should you have a skin exam, basically. And there's no real good guidelines available, so the American Academy of Dermatology has kind of given us some rough guidelines. So if you have a history of skin cancer, I usually like to see my patients every year. If you have no risk of skin cancer in your family, you have a very low risk of sun exposure, you covered up and protected, you've never had a sunburn in your whole life, you probably don't need to see me very often unless you know something is changing. And primary care providers, they can look at your skin too. They're more than willing to do that. So, that's always a good place to start since you go there every year anyway. If you have a higher risk, like you've had lots of sunburns in your lifetime, you have lots of moles, once a year is a good time to kind of have me look at the moles on the back. So I hope that answers your question a little bit.
Yeah, you talked about UV index of about 5 here. Let's say the lower 48 places the UV index of 10.
Uh-huh.
So for the same, would you expect in a place with a level of 5 you have twice as much exposure to get equivalent to the 10?
I don't I don't think I have enough knowledge about the UV index to speak on it, to be honest. Yeah, the UV index for me is just a guideline. I have to stay out of the sun so much anyway and be so careful that it's not something that factors into, am I going to wear my hat? Am I going to wear sunscreen? Because I wear all that anyway. So.
This goes back to the different layers.
Uh-huh.
Because it sounded like the basal cells aren't quite as bad as the squamous, and yet the basal is the lower layer.
Mm-hmm.
So, well, how does that work?
It has to do with how the UV rays interact with the cells, the skin cells. So, yeah, you're absolutely right. The basal cell tends to be less aggressive, but it's on the lower level, and it's hard to explain without getting too complicated. But the basal cells just tend to be very happy. They're just a little weed that grows in the garden. They don't go anywhere for the most part. So, and for some reason, the squamous cells, even though they're higher up on the outer layer, they just tend to be more aggressive. So I think it has more to do with the type of DNA damage that's done and how rapidly the cells start to divide and grow out of control.
What are age spots?
Age spots is in like liver spots or freckles that don't go away, or barnacles. They often are in sun-exposed areas, face, neck. Usually not. I mean, as long as they're not changing, not bothering, not painful, I don't worry about them. They're a sign of the times. You've lived a good life.
Where do you practice?
At TVC.
Two questions about protection.
Uh-huh.
Number one, how well is ordinary clothing protected other than the specialized stuff you were talking about? And number two, just within the last month, there was some kind of report that I saw on the news that the SPF factor was not really all that accurate. Either the manufacturers have been testing wrong or they're deliberately promoting it.
Yeah. So regular clothing does a great job of protecting against sun exposure. And I think if you look at like the farmer's tan, we see that, you know, men who work out in the field all day have a tan line, and so you can see right where their clothing was protected them and where it wasn't. So if you burn through whatever piece of clothing you're wearing, I would not wear that all day. It's probably not very good. But most clothing, just through the weave and the way it's made, provides really good protection. SPF factor, so the FDA has now required sunscreens to have an FDA approval. So that has come about, I think, in the last couple of years. So almost all sunscreens on the market now have FDA approval, and so they're under a lot more scrutiny nowadays. So I feel like anything that has the FDA approval on their label is good. It's a good bet. I brought a list of sunscreens that I like and I recommend, things that I think have had a lot of research and stuff that I use. So, yeah. I think it's in the back. So on your way out, be sure to grab that. I have a ABCDES of Melanoma too, so you can take that with you and look at all your moles.
How does sarcoma lead to death? What are the steps?
That's like a whole nother talk in itself. So it takes over, you know, you get this out of control growth. It can, like melanoma, I'll use melanoma as my example because I understand that pretty well. It can spread either through the blood or through the lymph nodes. It spreads to vital organs, brain, lungs, and it just continues to grow. And then it just kind of, it's like a bomb goes off, and it just spreads and spreads, and it takes over the machinery of your body. So your body is no longer functioning to live, it's functioning for the cancer to live, and so all your energy and resources go to that. And so a lot of times patients don't die of melanoma, they die of heart failure or COPD or something like that because the cancer is taking over their body.
Could you explain the Mohs surgery and what kind of cancer you can do that for?
So Mohs surgery is used for the non-melanoma skin cancers. It's for basal cells and squamous cells in high-risk areas or for high-risk patients. And it's a staged procedure where we remove what we see clinically. We look at it, we actually process it in real time in our lab, and then we look at it under the microscope. And the way we process it, we're able to evaluate the entire margin, so all the way around and the entire bottom. It's basically like taking a pie and making it flat, so that in each slide, I can see the entire tissue margin. And we just evaluate and make sure that all the cancer's gone. If there's any part of that margin that's positive, we just go to that part and go back to the patient and take just a little bit more and do that whole process again. Go through the slides until all the cancer's out. So it's a great way to treat skin cancer that's on the face, especially nose, ears, where you don't have a lot of tissue, or it's high risk because there's nerves nearby. So it preserves tissue, gets all the cancer out.
I know a lot of people who have done this doctor-prescribed regimen of cream that you put on your face and it exposes precancer stuff and then helps the cells grow up.
Uh-huh.
Can you tell us about that?
So we typically use Epidermis or 5-fluorouracil, which is an old chemotherapy medication. We use it for precancer cells, so the actinic keratoses. And it does a fabulous job of basically targeting those precancer, the early abnormal growth, destroying those cells, causing the cells to die, and then it sloughs off the skin. It usually gets real red and irritated in the process, but then after the patient heals, most of those precancers have been taken away, cleared up.
It's pretty effective.
It is, yeah. But not everybody responds. I mean, you know, there's always, nothing's 100% in medicine, just like anything in life, but I would say 80 to 90% of patients have a good response with it. And it depends how much sun damage you have as to how effective and long-term it's going to be.
And just one more question. So would a person's regular doctor be the one to say you should do this, or should we go see a...
I think I usually do it, but I don't we've got,
It depends on where you're at. Like if you're in Colorado, rural Colorado, and it takes a year to get into a dermatologist, then I used to be a good old country doc, then yeah, I would prescribe it. But if you have access to excellent specialists like you do with Dermis, then you refer it to a dermatologist.
They advertise in magazines to get rid of age spots. Does it work?
It depends. Sometimes laser works, but I don't really think, I haven't found a cure for them.
So for all the precancerous stuff, there's that cream, and isn't there some kind of light, and what's the difference between?
So yeah, you're right. I spoke about the topical chemotherapy cream. So there's also photodynamic light therapy, and that is what it's a doctor-applied treatment. So you actually come into the office and you put the medicine on, you incubate for an hour, and then you sit under a blue light for 15 minutes. And it essentially does the same thing. So the blue light activates the medicine, and the medicine has gotten into the skin cells that have the abnormal growth, and it causes the cell death. And yeah.
What are the pros and cons between the two?
So the blue light, it's one treatment. You come into my office, you're done in an hour. So a lot of men like that. People who are far away like it. Some people prefer to be at home and put the cream on themselves. It's a 2-week application cycle, and they just want to put it on. So it's somewhat patient preference. Depends where you live, things like that.
Sometimes when I use sunscreen on my face and then I'm outdoors and I'm sweating, it's in my eyes and it stings like crazy.
Yes.
So it makes me not want to use it. So what do you recommend that does not sting in the eyes?
So physical blockers, anything with zinc and titanium, I have a lot better outcomes with, because I have the same problem. My whole face will start burning with any of the chemical sunscreens. So I just have to use strictly physical blockers. So I have a list over there, and it breaks them up into the physical blockers versus the chemical ones. So try the physical blockers, and I think you'll have a much better result. I don't have that problem anymore.
And there's a list over there.
Yeah.
Yeah, a lot of people probably have the same idea where you take a macro lens, or I've got a simple microscope that plays in my computer. If you just kind of make an outline of the body and take a picture of any moles that change, and put a date on it, and if they change too much volume.
Yes.
Is there a procedure for that, or I don't know why people don't do that?
I often recommend that for patients too. There's a lot of new mole apps as well on phones. Yeah, so you can actually like keep it in your phone and take pictures of it. But yeah, especially patients who are very moly on their back or live far away, yeah, we'll take a picture, and with our EMR system, they can log in and look at it the way it was in the office and see if it's changed, and if it has, then we usually biopsy, depending on how significant the change was.
Do the cancers form at the spot of sun exposure, or can they form anywhere?
So most commonly they occur on sun-exposed sites, but they can occur anywhere. I mentioned earlier that Bob Marley died of melanoma, and his was on his foot. So he probably did not sunbathe, and his was probably had a lot to do with genetics. So you can get skin cancer anywhere. When I worked at some of the cancer centers, we had primary sites, GI tract, eyes, nose, ears, inside the ears, not just like on the ears. So yeah, the skin cancers can arise anywhere. Very, very rare for it not to arise in a sun-exposed area, but.
I have heard, and the author, John Updike, was a very severe case of the skin disease. I can't think of its name now. But anyway, I have that, and I've heard that it has advantages for the sunburn because it's a skin sloughing, and so that if there may be some evolutionary survival values to having psoriasis. Is what I'm thinking. Yes, have you ever heard that?
That there's a.
He would recommend, his doctor would recommend he go to the Virgin Islands
Oh,
and
yeah.
sun himself.
Yeah. No, we do see huge improvement with a lot of our psoriasis, our eczema patients who go to Hawaii. They'll clear up completely sometimes. Some people will flare. So there's not always 100% correlation, but yeah, a lot of people do get a lot better with sun exposure. And we think that it has to do with the decreased inflammation because the UVB rays can get into that second layer of skin really well, and they basically can kill all the inflammatory cells.
So if you burn a reasonable amount as a child, because we weren't as careful or as knowledgeable then, but now we're pretty careful, how's that affect your risk factor?
Your behaviors now definitely decrease your risk. So even if you had a few sunburns when you were younger, doesn't mean you're guaranteed to get skin cancer. And things that you do now will allow your skin cells to repair, and so it can lead to really good outcomes in the long run.
How direct is the genetic connect? My mother died of melanoma when she was 36.
Oh.
And they said that they were watching, there were 3 of the siblings. They said you need to watch the 3 siblings because if one shows a sign.
Yeah.
But sometimes they say that's really, really bad because it's a maternal one. And other ones say, no, it's really not as, it has more to do with the factors of your environment.
Yeah, when I see young people dying of melanoma, it definitely triggers family risk for sure in my brain. So I definitely counsel patients to have, and family members to have lots of skin exams in their lifetime. Watch their moles carefully, because we truly just don't understand the behavior of melanomas entirely. So family history.
We really don't know what's genetic and what's environment.
No, and there's a lot of genetic markers available now for melanoma, but we don't completely understand the behavior of those genetic markers. So if you were to test positive for one, it doesn't mean that you're going to get melanoma or that it's going to be aggressive. So
I've had basal cell. What are the chances of getting it again?
If you've had...
And it was from acne on my back.
Oh, from radiation?
I don't know.
Did you have radiation treatment for it? No? Okay. Well, once you've had one, you are at a slightly higher risk for getting a second one, more so than somebody who hasn't had one, so.
Radiation treatments for acne, I guess it's not done anymore.
No.
And the latency, I mean, people who've had it done are more susceptible to.
Yeah.
How long ago did that go out of favor?
50s or 60s, I think. I'm still seeing some patients come in who had radiation treatment for their acne, and I'm treating their skin cancers for it. So, yeah. Not in my lifetime. We didn't treat the acne that way. Well, oh, one more? Okay.
Maybe a helpful hint for people, because it seems to have worked for me. If you put on, slather your face with high quality, permanent, non-wash offable suntan lotion, and you sweat a lot on your face or head, and that runs down in your eyes, it will burn so badly. I had to be taken into an infirmary in Disneyland. So I found out that now I only use baby suntan lotion, and it doesn't burn as bad.
Yeah.
So if anybody has that problem,
Yeah, baby sunscreens, they usually are the physical blockers, so they tend to avoid all the chemicals. So yeah, they make really good sunscreen. So.